Great, thank you. And thank you everyone for joining us today. I'd like to welcome you to the Collaborative Core Center for Clinical Research Speaker Series. We appreciate you all taking the time to join us for this presentation. Our presenter today is Dr. Jean Liu. She is an assistant professor in the Department of Medicine in the Rheumatology section at Boston University School of Medicine. As a member of the COVID-19 Global Rheumatology Alliance and a member of its steering committee, she's involved in multiple projects related to data collection, analysis, and dissemination of the impact of the COVID-19 pandemic on individuals with rheumatic disease. In addition to co-authorship on publications from the GRA provider entered registry, she has co-led a literature review on acute viral respiratory adverse effects of commonly used anti-rheumatic medications and several peer-reviewed or invited commentaries on data for the use of hydroxychloroquine in COVID-19. Her presentation today is titled Updates on COVID-19 and Rheumatic Disease. Dr. Liu, whenever you are ready to begin, please do so.
Okay, thank you. So I am going to try to share this in the most appropriate way. You're only supposed to see a section of my screen for now. And then I can make this box correct. You'll be able to see everything. So you can see my actual slides. Okay. Thank you for inviting me. So I'm going to give a more clinically oriented update on COVID-19 for rheumatology. There will be methods and there will be research that I have taken part in, but I wanted to present sort of where we are at this point. And as I was saying to everyone at the beginning, where we are at this point keeps not only being relevant in terms of having to talk about COVID-19 and rheumatology, but it's ever changing still. Something that I really did not expect when I first started working with the Global Rheumatology Alliance or with any of this. So I have no disclosures. This is my black cat. Mike LaValle also has a black cat. So here's my outline. So I'm going to start with vaccination and responses to vaccination. This will really be my longest section because these are data that are still evolving now. And I'm going to then go into breakthrough infections, which is really the concern of what happens when the vaccination is not as protective as you're hoping in a subset of the population. And then after that, I'm going to talk about things both old and new that are relevant in the era of Omicron, which I think we're still in. And I'm going to end at the end on patient impacts and really touch on that briefly. So first, I'm going to start with the ACR vaccination guidelines, which remarkably, we're now in the 5th iteration, which were updated in February. So even though they're updated a month ago, they're still a little bit starting to become dated. But one of the recommendations that has not changed the whole time is that they recommend that everyone with rheumatic disease, regardless of the type or the medications that they're on, they should receive a recommendation to be vaccinated. And the only real contraindication is not related to the rheumatic disease at all, but would be for people who have a severe allergic, like anaphylactic reaction to vaccine components. So in the last few versions, the ACR has recommended the mRNA vaccines over Johnson & Johnson, and they don't have a recommendation for Pfizer versus Moderna. And they also have some wording about a supplemental third dose, which really is considered the last dose in the primary series for people who are considered immunocompromised. So it's 3 doses, and then the booster, which is also recommended here, would be an additional 4th dose after that. And they really support the CDC recommendations in terms of immunocompromised definition, as well as the schedule for a booster dose per the CDC. And at the end, all of these recommendations are made regardless of whether someone has had a natural COVID-19 infection. There's no difference in the number of vaccinations or the timing with regard to that. And the ACR also has recommendations for medication holding or timing of the medications with regards to vaccination in order to improve the immune response to the vaccine. So they've had a bunch of changes in this section, but currently they recommend holding methotrexate, mycophenolate, and JAK inhibitors for 1 to 2 weeks after each vaccine dose. And before, they had more medications that kind of fell under this category, but this is currently reflective of available data that we have. And then the guidelines have more specific information about timing for certain medications: abatacept, belimumab, cyclophosphamide, and rituximab. There are multiple stars after rituximab because the ACR has acknowledged that optimal timing for vaccination is really nuanced and depends on many individual factors, including underlying disease control. And even then, it's still hard to say what's best, but we'll talk more about rituximab. We will talk a lot about rituximab. So beyond the guidelines then, patients and clinicians have had lots of questions and concerns regarding vaccination in terms of reactogenicity or side effects, and immunogenicity or the response to the vaccine. So under reactogenicity, we have side effects from the vaccine. And if I have my certain rheumatic condition or I'm on these medications, are my side effects going to be worse than general population? Am I going to have a flare of my underlying rheumatic disease from getting this vaccine? And then immunogenicity really concerns, am I going to not respond as well, not be protected as well compared to someone in the general population or someone who doesn't have my condition, who isn't on the medications I'm on? And we're going to split this into B-cell humoral response and T-cell mediated response, because that's how laboratory-based studies have assessed this. So I will be summarizing how our understanding has gotten more nuanced over time. So we'll start with reactogenicity, and we'll start with data from these two registries. So the first, EULAR-COVAX, is a physician-entered registry from the EU only. So these are rheumatology patients who have been vaccinated, and their physician, usually a rheumatologist, entered their data on if they had any side effects. And the second registry was the Global Rheumatology Alliance, or GRA, vaccine survey. And this is patient-entered, and we were requesting information from rheumatology patients whether or not they had been vaccinated at that time of the survey, because this was still in spring of last year, and this is global, so not restricted to the EU. And I wanted to start with the registries and their makeup, because when I'm presenting these data, I want you to consider the limitations, particularly in regards to selection bias from who might be more likely to respond. Of course, since they're voluntary registries, you've already got selection bias there, but thinking about physician-entered versus patient-entered data. So flares of the underlying rheumatic disease after vaccination. So in the EULAR-COVAX physician-entered registry with 4,600 patients, 4.4% had any flare, and 1.5% had a flare that required some medication change after the vaccination. And then in the GRA vaccine survey of patients, nearly 3,000 respondents, 13% had a flare lasting at least 2 days after vaccination, and nearly 5% had a flare requiring a medication change. And the frequency of flares were similar across vaccine types as much as we could tell. And then in general side effects, these were pretty common. So 37% reported any side effect in the EULAR-COVAX registry, with less than 0.5% reporting serious AEs. And in the publication, they actually have a table listing exactly what those were. In the GRA vaccine survey, similarly, you had a high frequency of participants reporting some adverse event lasting at least 2 days. And you can see at the bottom that these side effects are common, and they align with those that are reported in the general population studies. So I wanted to highlight a couple more studies that have focused on specific questions that have come up in clinic. So in the FORWARD registry, they found that Moderna was associated with more side effects compared to Pfizer. And this is something that's also been seen in the general population. So that's a question that people might have. And then in Covaripad, which is a prospective cohort that I'm going to discuss a bit more in detail, reactogenicity was associated with immunogenicity. So that means the number and degree of side effects actually correlated with the humoral response that was tested. So this was a question that had come up a lot. So I really appreciate that the investigators actually use those data to answer this question. And both of these have been presented at last year's ACR. And then what about medication holding for vaccination, like I discussed earlier with the ACR guidelines? So as expected in Arthritis Power, which is a patient-powered registry, medication interruption, like holding your medication, was associated with higher odds of having severe flares. And in the Johns Hopkins cohort, holding mycophenolate was actually associated with better humoral response. So recall that holding mycophenolate for 1 to 2 weeks after your vaccine dose is still recommended in the current iteration of the ACR guidelines. So now moving on to vaccine immunogenicity and those with rheumatic disease. So I'm going to start with the B cells, and we're going to go into the T cells. So the first studies that came out looked at the humoral response by assessing seroconversion and by use of neutralization assays. And one of the biggest to report data was Covaripad, which was a collaboration between WashU and UCSF. Alchem is the PI. They prospectively enrolled people with chronic inflammatory diseases, so not just rheumatic diseases, but also MS, IBD, uveitis, and they had healthy controls who were healthcare workers. So in this visual abstract, they found that anti-spike antibody titers following 2 doses of an mRNA vaccine were reduced by 36-fold in those on B-cell depleting therapies, such as rituximab, and then there was less of a reduction seen for other medication classes. And when we look at the cumulative data for humoral responses by medication class, again, for B-cell depleting therapies like rituximab, they're consistently worse in multiple cohorts, pretty much across the globe. And next, for mycophenolates, the data in people with rheumatic disease appears similar to data from solid organ transplant cohorts. So they have low seroconversion after vaccination. There are some nuances that weren't initially captured at this point regarding the underlying immune system and how that might differ between people who are transplant recipients and those who have rheumatic disease. But if we just look at seroconversion neutralization assays, it looks not as bad as B-cell depleting therapies, but concerning. And then data for steroids are mixed, and unexpectedly in the Covaripad cohort, at least, they didn't see a dose response. They saw that no matter what the dose was, even if it was as low as 5 milligrams a day of prednisone, they still saw this, this lower antibody response. But study PIs acknowledged that their data is confounded by the other medications that participants were on, and it's hard to extract what is just the effect of the steroids alone on the humoral response. And then looking at the T-cell mediated response. So starting with the B-cell depleting therapies again, if you do not have any peripherally circulating B cells, so if you check a CD19 level at 0, then they're likely not going to have a detectable humoral response following vaccination. And all of this, as you would expect, depends on the time since the last infusion. So if you're within 6 months since the last rituximab infusion, you're likely not going to have any circulating B cells peripherally, and you're likely not going to make a detectable humoral response. But if you go further out, 8 months, maybe 9 months, if you can hold the rituximab for that long, then you're more likely to generate a detectable humoral response. And then later on, studies showed that despite a lack of seroconversion, people were able to generate a cellular immune response. And the level of protection here remains unclear based on these lab studies alone. And there are also some conflicting data here as well. So At this point, we need to think about distinctions of between the presence of a T cell response that you can measure in these studies and the qualities of that response. And we still don't know how that translates to actual protection in the real world. So 2 more classes of medications besides B cell depleting therapy. So methotrexate, when you look at the totality of evidence, it's also kind of confusing, at least to me. So does it attenuate the humoral response, the T cell mediated response, or both? So for attenuating the humoral response, you have these 3 studies, including this large UK psoriasis cohort, where they did show that, but in the UK psoriasis cohort, it was only apparent after the first dose and didn't seem to affect things after the second. And then in these 3 cohorts, you saw that methotrexate impaired the T cell mediated response. And in a French cohort, this was apparent even after a 3rd dose. So the question still remains, what's the quality of this response that's generated if you're on methotrexate and you don't hold it? And recall again that methotrexate is one of the medications that are recommended to be held for 1 to 2 weeks after vaccination. And then you have summer 2021, and the Delta variant comes on. And in this French study, if you focus on rituximab, so they are showing neutralizing titers of sera against the Delta variant in red and against Alpha variant in blue. And in most groups, the neutralization for Delta is lower versus Alpha, but in rituximab, it's just bad for both. So if you look at this in a slightly different way in these circles, in this blue here, there's only 1 patient that had an adequate neutralization response against Alpha, and there's nothing for Delta for the people who are on rituximab. So at the same time that the Delta variant was circulating, this German cohort found that neutralization levels dropped more for TNF inhibitors over time than other medications. So then we become concerned about this group of people who we were not as concerned about before. And similarly in coverapads, neutralization titers waned below protective levels for most groups over time, over 5-6 months, but it was really apparent for TNF inhibitors. But they did show that if they were given a 3rd vaccine dose, then they were able to boost the serum neutralization against the variants, against Delta. So waning responses were concerning, but it was reassuring that this 3rd dose could boost the response back up. But then there's questions that still remain about, is this enough for full protection? So in summary, this is a nice Nature Reviews Rheumatology article with a great set of figures. This really shows the B cell response effects and the medications that are most suspect. So B cell depleting therapies, obviously. And for T cell response, you have B cell depleting therapies, but also abatacept just by its mechanism of action. And then these antibody response effects, including effector functions. You've got TNF inhibitors here as well. And then you have this group in green, other biologics are IL-17, IL-12, 23 inhibitors, where you don't think there's any direct effect with vaccination. So then the CDC in late 2021 updated their guidance on boosters for the immunocompromised, and they include this additional 3rd shot to the original series and a booster 5 months after the primary series. And they also recommend that for people who had received a J&J vaccine to get an mRNA booster following that. So data for 3rd doses for the immunocompromised, if we look at people who failed to seroconvert, especially people who are on rituximab, so if you see that if you give them a 3rd dose, they have a better, although not great, humoral response, and they have an intact T cell response. And a mix and match strategy where you go for a different vaccine than your primary series. Studies so far haven't shown that there's a clear additional benefit, but there's also no clear harm either. And then what about 4th doses? If we call that the 4th dose is actually the booster dose for the immunocompromised. So the Hopkins cohort published this case series of 18 people who had received a 4th dose at that time. and most of them were on mycophenolate, and most held their medication for the vaccine. So seroconversion was pretty high after this 4th dose, but there are still 2 people, disappointingly, who were on mycophenolate who weren't able to hold their medications, who still had no immune response. So we need to think about a strategy beyond vaccination, and I'm going to talk about this in a bit. So to summarize this long first section, look to the ACR guidelines and shared decision-making for holding your medications for vaccination. And side effects are common with vaccination, flares uncommon, but they should be things to be discussed, but they shouldn't hold you back from recommending vaccination for those who still need to get vaccinated, whether it's additional doses or boosters. And reduce immune responses and B-cell depleting therapies, unclear how protective their T-cell mediated responses are at this time. And for medications like methotrexate and TNF inhibitors, we still don't have the full nuanced interpretation of what it means when we see the data I just presented. And the CDC and the ACR both have recommendations for boosters for the immunocompromised, and they're recommended. So moving on to breakthrough infections then. So the first data came out of Israel. So among healthcare workers, they saw that breakthrough infections were associated with lower neutralizing antibody titers. And they presented this case series of 152 people with breakthrough infections, and 40% of those were immunocompromised. And they had this sobering majority who were severely ill, 22% mortality, but you have to remember that these are the earliest cases, so there's a lot of selection bias, but these are the first data we had for breakthrough infections. So before Delta, in the GRA, we looked at breakthrough infections in this case series. So we had 197 that were considered partially and fully vaccinated by ACR or by CDC definitions. And when we focused on the 87 who were fully vaccinated, so at that time it was 2 doses of an mRNA vaccine or 1 of J&J, we had 22 who were fully vaccinated and who were hospitalized. And what stands out for these 22 is that 9 of them were on B-cell depleting therapies, and over a third had comorbid lung disease. So these were our real world data about people who were actually getting breakthrough infections following vaccination. So then if you look at something that has general population comparators and larger numbers, this study that's in JAMA uses a large collaborative registry that's EHR based, and they have data pre and post Delta. And the only rheumatic disease they look at was RA, but among people with RA who are fully vaccinated, they had a higher rate of breakthrough infections compared to the general population. And the incidence rate of breakthrough infections was higher in the Delta era than before. So all of this is stuff we would expect, but these data really provide further information about that. And then more recently, we have this large Indian cohort of about 600 people with autoimmune rheumatic disease, and they had received AstraZeneca, and they measured their antibody titers. And they had a breakthrough infection frequency of 7.4% during the Delta wave. And they were also able to demonstrate that not having an antibody response to vaccination was associated with that breakthrough infection. So this also brings up the question of, should we be measuring antibody titers? And this is another clinical question, another research question that we've been asking for quite a while. And the ACR guidance still says, no, we should not be doing this, but this is something that's always up for discussion as we get more information. So to summarize, for breakthrough infections, again, B-cell depleting therapies are the most concerning, and poor antibody response is associated with having a breakthrough infection. And we know, at least from the RA data in the N3C cohort, that breakthrough infections are worse in RA versus general population, and that it's higher with something like Delta. And we don't have Omicron data. So then we come to the Omicron variant at the end of November, and these graphics are from Creaky Joints, but they had reached out to ask for advice for how to handle this surge. And in thinking of how to respond, they went back to the basics, which is what I'm going to present now. So when you ask about risk for those with rheumatic disease, you could look at rheumatic disease versus the general population on outcomes of getting infected, being hospitalized with COVID, dying from COVID. So these questions are addressed in two different literature reviews from EULAR and from the GRA. And most of the conclusions are actually conflicting, but I think it really reflects the quality of the data and the variations in study design and population. So for the first outcome of getting infected with SARS-CoV-2, EULAR, looking at 26 studies, no evidence of increased risk of infection, but the GRA study of similar number of studies included, they found a higher prevalence of infection. If you look at the outcome of COVID-19 hospitalization, then in the EULAR study, they found an increased risk of this for rheumatic disease versus the general population. The GRA study didn't see that there was an increased odds of hospitalization. So let's look at two representative studies from countries with granular registries that are well poised to answer this question. So if we look at this one, they looked at inflammatory rheumatic disease versus the general population. And for hospitalization for COVID-19, this was 1.5 times higher risk. And then when you break it down to RA vascularized subgroups, they still have a higher risk of hospitalization versus those who did not have these diseases. So looking at Sweden, inflammatory rheumatic disease versus general population for the risk of hospitalization for COVID-19. Again, you have a higher risk for rheumatic disease. And again, when you break it down, RA and other rheumatic disease, you still have this higher risk that you see versus general population. And then finally, in North America, in this Ontario administrative data cohort. So again, hospitalization, they have a higher odds in people with rheumatic disease versus general population. And when you break it down, these were the different rheumatic diseases that had the higher odds of hospitalization for COVID-19. So maybe if you look at the studies that have the best population-based data, you would then consider maybe the hospitalization risk is increased if you have rheumatic disease. So then what about more severe COVID outcomes like ICU admission? EULAR didn't see an increased risk, but they only had 2 studies. And GRA, 7 studies, didn't see that there was higher odds either. I'm going to skip over for the interest of time for the next couple of slides, but there are certainly studies that have gone more granularly into these severe COVID outcomes, like this TriNetX study, where they looked at risk of hospitalization, ICU admission, and other things like renal failure. And this Optum study, where they looked at all of these outcomes besides hospitalization or ICU admission for people with RA. So finally, the last outcome would be death from COVID-19. And again, this is discordant. So no increased risk of COVID-19 death out of these 6 studies in the EULAR lit review. And in the GRA lit review, there are a higher odds of COVID death in these 13 studies. And so really, what is the summary then? So you've got these conflicting results of these 2 systematic literature reviews. And I think I would proceed with some abundance of caution and say that probably there is some modestly higher risk of infection, hospitalization, possibly with severe COVID-19 outcomes versus general population if you look at rheumatic disease overall, because I would be very hesitant to summarize this as that there is no difference in risk compared to the general population, because can't really say that, especially looking at the studies that have a low risk of bias, the Danish, the Swedish study, the Ontario database. So this is what I would conclude. Okay, so I referenced the GRA, and we've all heard the story about how clinicians, researchers, and patient partners came together in March 2020, and we launched this physician registry where we include the people with rheumatic disease who had diagnosis of COVID-19, and we have collected a ton of data. So just as a reminder, what questions is this GRA registry able to address? So among people with rheumatic disease and COVID-19, is the type of rheumatic disease, is that associated with these outcomes of hospitalization or death due to COVID-19? What about medication classes, medications that they were on at the time of diagnosis? Are these associated with hospitalization or death due to COVID-19? So the GRA does not have a general population comparator, and it doesn't collect data from people who did not have COVID-19. So these are the main caveats that you have to remember, apart from the fact that this is, again, a voluntary registry, so selection bias remains a concern. So in our first major study of 600 cases, we looked at the outcome of hospitalization for COVID-19, and risk factors were older age and comorbidities as expected. And in the second study of 3,700 cases, we found the same risk factors for death from COVID-19. And in addition, we didn't see that there are specific rheumatic diseases that associate with higher odds of COVID-related death. And we've also performed several disease-specific analyses where we've been able to model associations that were specific to lupus or vasculitis or RA, for example. But we did see that certain medications were associated with higher odds of death. So specifically, rituximab was associated with higher odds of COVID death in this study. And this was before vaccination and any of the vaccine immunogenicity data. So rituximab has really remained a key player throughout this pandemic. So when I presented these data at ACR in 2020, there was a really good audience question regarding a possible statistical interaction between disease activity and steroid dose. So this plot visualizes that interaction. So for those who are in remission or low disease activity here in blue, even at the higher doses of steroids, you don't see that they have an association with the outcome of death. But for those in red who have moderate, higher, severe disease activity, you see this association with death for all the doses of steroids or even people who are not on steroids. So higher disease activity seems to be the risk factor for poor outcomes with COVID-19. So in summary, older age comorbidities were associated with poor outcomes, worse outcomes in people with rheumatic disease and COVID-19. And the things to really look out for, think about rituximab, steroid use, although maybe it's more about higher disease activity that is associated with worse COVID-19 outcomes. So these are the things that I remind people of, that even if we do not have a lot of data about Omicron, about different variants, that I think these things are unlikely to change, that rituximab is going to be continue to be a key player in terms of being a risk factor for poor outcomes or not responding to vaccination. So briefly, I wanted to talk about the novel therapies, and this is a section that I've had to change the most because now sotrovimab, this monoclonal antibody that retained its efficacy against the OG strain of Omicron, it's got lower efficacy with the BA.2 variant. So this monoclonal antibody that I was trying so hard to get high-risk non-hospitalized patients to get it within 5 to 10 days of symptom onset, this one dose, now it's not for use anymore for areas that have a high prevalence of the BA.2 variant. So not sure if this will come back, but already the other monoclonal antibodies that we were using before, like the Regencov, the Regeneron cocktail, those are already out with Omicron because they did not have enough efficacy against variant. Then we have this newer monoclonal antibody from Lilly, bebtelovimab. It's got similar indications, so high risk, not hospitalized, 12 years or older, and you have to get it to them within 7 days of symptom onset. I've not been able to give this to anyone or how to give this to anyone yet. But it's one dose, it's IV, and there aren't really any significant indications or precautions to think about. And then we've got the 2 oral antiviral pills. Paxlovid is the one that's the recommended one. This is boosted with ritonavir. You're giving it to high-risk, non-hospitalized people within 5 days of symptom onset. And it's a twice-a-day dosing for 5 days. And you have to really think about the drug-drug interactions of this one because it's got a lot of them. Liver disease, CKD, and then the drug-drug interactions that are more important to us are probably colchicine, steroids, tacrolimus. But these are things that can just be held while they're taking the Paxlovid, so that hopefully makes it a little bit easier. And the other oral antiviral, molnupiravir, sort of similar indication and time window, it's just lower efficacy. And drug-drug interactions are fewer, and the contraindications are really pregnancy and children under the age of 18. But similarly, twice a day, 5 days, give it as quickly as basically they can prove that they have COVID. And then Evusheld is the pre-exposure prophylaxis. So this is a combination of 2 monoclonal antibodies. They have retained their activity against Omicron, including BA2, as far as we know, and they're given IM, but there has been a lot of effort to try to get this out there, but we still have tiers for risk because we can't just give it to everyone that we would deem to be immunocompromised or possibly high risk. So due to the vaccine supply and access, we've had to have form tiers for people who can get this. It was 2 doses IM, luteal preferred, but then with the data about Omicron subvariant BA2, they've had to double the dose. And I haven't heard updates on whether this is like changed, but on the day that they announced it, like a few weeks ago, it was IM ×4, which sounds pretty horrific given, again, the luteal administration. But not a lot of contraindications or drug-drug interactions to really think about. So at least there's that. You just have to figure out what your tiers of really high-risk patients are who should get this. So when all these medications came out, there are all these issues surrounding resource allocation. And this was an article that came out in January, which was basically talking about how people didn't really have access to these medications. We weren't really seeing the supply yet. And the ACR recommendations from February, they only are able to go as far as saying, if your patients are high risk for poor outcomes, they should receive a monoclonal antibody therapy as pre or post-exposure prophylaxis per the EUA. But they can't, of course, say like which patients should go in which tier. That's not the role of the ACR guidelines. So going back to this nice review that just came out, so it's got this timeline of just broad recommendations for what people with rheumatic disease should do. So starting with people who have not gotten infected. So you're getting vaccinated, you're getting a booster dose, which is a 4th dose. And then you're not stopping your medications out of concern that you might get infected, but you are trying to control the rheumatic disease as much as possible and minimize steroids as much as you can while maintaining disease control. And then for those who are high risk, you have to consider giving them Evusheld as pre-exposure prophylaxis if they're eligible at this time. And then moving forward, if people do get infected, with mild infection, they should be counseled on how to hold their medications, their immunomodulatory medications, until they're no longer symptomatic and they're getting better. And you're trying to get them access to things like monoclonal antibodies, if possible, otherwise the oral antivirals, especially Paxlovid. And if they become hospitalized with more severe COVID-19, then there aren't really different recommendations or different treatment algorithms that I'm aware of for someone who is who has a rheumatic disease or is on immunosuppression. So this is just general information. So with that, I'm going into the very last section, which is really just considering where we are now. So this is a slide that I showed at ACR in 2020. So this is a long time ago, but I was highlighting some studies where they looked at medication changes that were mostly patient initiated. And these are medication changes of their anti-rheumatic meds out of concern that they were going to be at risk for poor outcomes if they were continuing these medications. So in the Ford registry, they did this mixed methods study, and they brought out this theme of concern about infection risk because of these medications that people are on. And then in this Danish survey of their big registry, they had 4% of people who were using DMARDs who had changed their medications at the very beginning during the lockdown in March 2020. So not too many people, but when you look at this RLAR survey, which is the Arab League Against Rheumatism, this is a multinational effort. And when they polled their patients, they had a larger frequency of people who had to stop or decrease their medications due to the concern about infection risk. And these are really just survey studies, but what can you really say about this is that the background to the RLAR survey is that they also found that people had a really hard time interacting, communicating with their physicians because they didn't really have a high uptake of telemedicine or high availability of it. So if you think about how if you're not able to message or have a televisit with your rheumatologist, and you're really concerned that your medication is the thing that's going to put you at risk, you might be more likely to change or stop your medication because you think that's the thing that might help you the most. So since these data came out, since that time, we've gotten recommendations, guidelines from many different organizations. We have much more guidance on what to do with medications, but I think these kind of things like these patient concerns that are hard to answer in real time, hard to address with data, these are things that remain an issue. And communicating with patients when you're not able to see them in clinic, and maybe you're not able to do televisits efficiently, this remains an issue. And then in terms of patient impacts, we have other studies which look at things like the impact of the lockdown in 2020 on disease activity and physical and mental health. This came out pretty early on, looking at how, like, if you're in lockdown, you might not be able to perform physical activity, exercise, and how that might affect disease activity itself. But then you also have now some longitudinal assessments of things over time. So even without like persistent lockdown, having these multiple waves of COVID take over and impact healthcare access, healthcare delivery, what does that do to mental, physical health? What does that do to physical activity? So we are having more of these studies that look at this longitudinally. But what about long-term effects? So we are starting to see some reports, and this is a sobering paper out of the UK that just came out. So as the pandemic's dragging on, there's continued uncertainty about risk or what to do with your medications, or just what to do in general to protect yourself. It's really an issue for patients and the providers, and this study really points out these issues related to trust. So this is trust from the patient perspective. So they're talking about the government, the NHS, their providers, and then there is also there is also another graph showing the providers and their trust in like their hospital and in the government. And it's quite, I guess, depressing is one word you could use. And this has also been highlighted in the lay media. So as we lift restrictions that have helped protect those who remain vulnerable, despite them doing everything they can, despite them protecting themselves, becoming vaccinated, how do we really move forward? And how do we continue to address disparities in access to measures like Evusheld? How do we educate patients on how to take action, but then acknowledge that we shouldn't really leave it up to themselves to do everything to protect their health? Because you can certainly educate patients on like the appropriate masks to buy, and how to contact us if they were to get sick so that they can get access to antivirals, but how much of that should be on them, and especially when they've already dealt with 2 years of these uncertainties and many years before that of dealing with their own healthcare. So these are really the questions that really remain, and kind of wanted to leave it at that for the talk. So thank you for your attention. I think we have 13 minutes till the hour, and I want to acknowledge the Global Rheumatology Alliance Steering Committee. That's our Zoom screen from 2 years ago. And then I want to acknowledge my section of Rheumatology at BU for their support. And then with that, I can stop sharing. Thank you.
Okay, thank you very much, Dr. Liu. We do have time for questions. And I'd like to let you all know you are welcome to either unmute yourselves to ask your question, or if you want to post something in the chat, I can be monitoring that. So any questions?
Oh, there's a comment that I appreciate from Grant Schulert that Evusheld will be reformulated back to 2 injections. That's good. But there's still 2 IM gluteal injections, I'm guessing. So, because someone I think was asking, what if it were given IV, but I am guessing the route isn't conducive to it being protective. Anyone have any questions? Does anyone have the question that everyone always asks when this talk is given? Let's see if anyone guesses what that is.
I would guess the question is, when's the next variant coming?
Oh no, I don't know. If I said I knew, then I would align myself with those people who make predictions all the time on Twitter, and I don't want to do that. The question that everyone always asks is, what about sulfasalazine? And I actually made some slides for that. So let me cancel out of that. Let me just share those slides. I'll just share them like this. So, so this is a slide I showed where I pointed at rituximab, but sulfasalazine's here too. And in the GRA data, it's associated with higher odds of COVID-19 death. And when we saw this, and we did a bunch of sensitivity analyses, and it just kept coming up, we were quite surprised because this is a medication that we don't even consider to be immunosuppressive. We don't consider it to be like a medication that we give to people who have high disease activity or severity of disease. It's something that we don't think works like that great for control. It's more of something you put in for combination therapy. So what was the deal with that? There were some like basic science studies showing that it might have some effect on the ACE2 receptor and viral binding, possibly, but like pointing out that there's biological plausibility from in vitro studies is also concerning given like the situation with like things like hydroxychloroquine. So we said maybe it's confounding by indication, but then we saw in the IBD registry, which was sort of the IBD equivalent of the GRA, that they also, when they did their first analyses, saw this. So we were thinking maybe it's real. We're seeing it across 2 different registries of different patient populations. But when the IBD registry grew bigger and they had many thousands of patients, they were able to perform analyses that like no longer show that association. So now they're getting completely no results. So they think that it was all due to confounding by indication at this point. So maybe that's true, but that is my attempt at trying to resolve that question. And every other time that it's been asked, it's just been, we don't know, confounding by indication possibly is all we've been able to say.
Other questions?
Well, if there are no other questions, I want to thank everyone for coming and supporting me. I see you all, Kara and Kathy and Mike.
Yeah, so thank you everyone for taking the time to join us today. You should have seen a poll pop up, and so please, before you drop off today, please do just take a minute to fill that out. And again, we appreciate you joining us, and thank you again, Dr. Liu. I think you just provided all the information that there were no questions that remained. Thank you very much, everyone. Have a great day. Have a great weekend.
Thank
Stay
you.
healthy and
Bye.
well.